look at some classes of your viruses, and that's the sheet we passed out this morning. It should be in your handout also. So after classifying the viruses, then we will look at the usual ways, the means by which a virus causes an infection, and then we'll start looking at the drugs that you use to treat such infections. Okay, so if we look at a virus is actually a lifeless, particle. It is believed to be just a nucleic acid that is surrounded, that is genome, that is surrounded by a protein coat. And that's about what it is. Very tiny. 30,000 viruses can fit in one black-eyed pea. So it's very small, and it's a non-living organism because it's lifeless, or particle rather. And you have several of them that we come into contact with on a daily basis, and they are usually divided into two main groups. It's just based on the genome that it contains. So we have DNA containing viruses, and you have RNA containing viruses. And that's how they're divided up. And under your DNA containing viruses, you have many groups. For instance, you have your adenoviruses, and those are the ones that cause common infections. When you have your upper respiratory viral infections, usually due to adenoviruses. If you have some lung infections due to viruses, they're mainly adenoviruses. Those are numerous. Those are the ones that you always tell patients, just drink some soup, get some bed rest, and it will blow over. The virus will run its course, like we always say. And then you have a large family, which is the herpes family. And we'll come back and describe those. And then you have the papovaviruses. That's another large group. And then the pox viruses. And you see, for the herpes family, you have your HSV1 and HSV2, herpes simplex virus. So herpes simplex virus 1, herpes simplex virus 2, and you can have your Epstein-Barr virus, EBV, Epstein-Barr virus, which you see there. You have your VZV, which is varicella. Okay. People say varicella, I say varicella. That is how it should be pronounced based on its origin. And then you have the herpes zoster virus. The Z is zoster. Okay. And then you have some human herpes virus 6 and human herpes virus 8. So you have many of those. And then you have your CMV, cytomegalovirus. So HSV1, HSV2, those ones we will discuss in detail because we will be using a particular drug that works against them when we get to drugs. Epstein-Barr virus, that's one of those viruses that can cause cancer. So when we say a virus can cause cancer, that's one of them. You see, it can give you that Burkitt's lymphoma. And Burkitt's lymphoma, okay. Burkitt's lymphoma is a type of cancer. It can also give you your nasopharyngeal carcinoma, and it can cause what they call Epstein-Barr virus disease, which is really more like mononucleosis, as you can see there. So Epstein-Barr virus is a herpes virus. Okay. VZV, that's the one you say causes chicken pox. And then the HZV is the one that is associated with Shingrix. Basically, when VZV infects humans, it hides or it stays in the system for the lifetime of the individual. So if you had chickenpox, that virus will be in you forever. And as you get older, in old age, this is where the chickenpox virus would hide, you know, and it can stay there for a long time, and then during old age, if your immune system goes down or weakens, then your VZV can present as your HZV, which then produces that Shingrix. So it's not that you have a new virus that develops as HZV, actually. It is the VZV that is representing itself as HZV, which then causes Shingrix. Human herpes virus 6, that occurs mainly in infants, in neonates, usually around the age of 2. And it also lasts a long, long time. Usually the lifetime of that baby, once they contract it at that age, it lasts essentially forever. And that's the condition that the baby would have with that HH6, roseola infantum. And from the name, you can tell what the color would look like. The baby will have some reddish coloration of the cheeks, and of course, it is occurring in infants. Okay. And HHV8, that's the one that is implicated in what you call Kaposi sarcoma. That is a purplish discoloration of the skin. It is a cancer, actually. It is a cancer, and you see it in immunodeficiency situations, particularly when the individual has that HIV/AIDS. And so it is actually a diagnostic tool for HIV/AIDS. So it's very, very clear cut, and it is basically due to that HHV8 and cytomegalovirus.
For HHV8, you said they will have a purplish color?
What they will get will be Kaposi sarcoma. The description of that Kaposi sarcoma is a purplish discoloration of the skin. So when you see an AIDS patient with purple discoloration of the skin, they have Kaposi sarcoma. And it's one of the diagnostic infections for AIDS, or HIV/AIDS. Okay. CMV. CMV causes mainly retinitis. And like you said, it is the #1 cause of blindness in patients with HIV/AIDS. But it can also produce some pneumonia as a manifestation. And also some hepatotoxicity or liver disease. So those are your herpes members. And if you're thinking about your cold sores and genital herpes, people always say that HSV1 causes cold sores, and that HSV2 causes genital herpes. Okay. That is not wholly true. If you put the word most in there, then that would be true. In other words, both HSV1 and HSV2, both of them can cause cold sores. Okay. And both of them can also cause genital herpes. It is just that HSV1 mostly causes cold sores, and HSV2 mostly causes genital herpes, but both of them can cause each of those conditions.
There are some people never develop any like cold sores. Those people never get like those herpes viruses.
Some people never get cold sores.
Yeah.
They just haven't been infected with some hidden virus, because when this herpes virus infects, just like that VZV that we were talking about, it can hide in the nervous pathways. And then when you have, say, a bacterial infection, the bacterial infection, say like you have pneumonia, it can reactivate the dormant virus. And that's really when you see the cold sore. So if somebody has never had the cold sore, it just means they've not been exposed to herpes virus, particularly one or two. Papovaviruses, well, that is another group of viruses that you can divide into three, because that's how they got the name. The Pa is your papilloma virus. Okay. And that's the one that causes genital wart. Okay. Condyloma acuminata is the clinical term or name for genital wart. Okay. And the ones that are usually involved are 11 and 16, but when we get to another section, we will give you all of the series or subtypes of your papilloma virus. So that is part of the Papova group of viruses. The PO there stands for polyoma. And whenever you see that oma, it means tumor. Okay. And your polyoma virus produces one deadly condition in which you have the so-called progressive multifocal meningitis. Okay. It can you can also see it producing like that leukemia, which is why you have the OMA there. Now, PML can kill very easily. It's a very serious condition. And the virus that has been associated with PML is a virus that is called JC. And JC refers to John Cunningham. Okay? John Cunningham. And so John Cunningham virus is basically the cause of your PML. And of course, it is a polyoma virus, which belongs to the Papova virus group. And for the VA, you have, the VA stands for vacuolating. like a vacuole. Vacuolating virus. The most common one there is your SV40. And the S refers to simian. So simian vacuolating virus number 40. Okay, simian vacuolating virus number 40. The 40 was just like to identify a particular number when they were looking at the viruses that first came from your rhesus monkey. Okay. So simian refers to monkey. So a monkey virus, and it was originally obtained from rhesus monkey. So a monkey virus, like simian, that can cause vacuoles, like what actually came from Latin, okay? And it just means space or an empty, space, an empty box or tissue. Okay. And then number 40. SV40 has been implicated in infections of the brain, so it causes a lot of infections in the brain and the bones. It can also produce a lot of lymphomas. And also mesothelioma. All right, so you see, it is not only asbestos that can cause mesothelioma, that long condition that can eventually become, malignant. Okay. Okay. So asbestos causes a lot of mesothelioma, especially malignant mesothelioma. And that was the reason why the government had to ban the use of asbestos in building houses, So, but it's not only asbestos that can do that. SV40 can also give you that malignant condition when it affects humans. Okay. And then for the pox viruses, that's the other group for your DNA containing viruses. The pox virus, some examples of your pox virus will be the Yersinia virus. One is variola, one is Yersinia. Okay. And one is called MP, which is monkeypox. Monkeypox. We know that your variola can produce your smallpox, and then Yersinia will cowpox, and MP will be monkeypox. So those are some conditions that your DNA containing viruses can produce.
Okay, well, you said Vaccinia produces monkey,
No, this is
cowpox?
monkeypox.
Cowpox?
Mhm.
Okay.
This here,
Mm-hmm.
this is monkeypox. This is cowpox. This is smallpox.
Thank you.
So those are quick looks. And you know, there are certain viruses that you always call, you know, liver or liver viruses. Hepatitis B. Okay. Hepatitis B, among all those hepatitis viruses, is the only one that is DNA containing. All the others are RNA containing. So I can put hepatitis B virus under DNA. Now for the RNA viruses, you have some arenaviruses. Okay. And the arenaviruses the arenaviruses can include ones like your Lassa fever virus. That's a type of arenavirus. And the Lassa fever virus is sometimes referred to as the swollen baby virus or infection. Okay. And that is because one of its characteristic features is an edema of the face. So it looks like the baby's face is swollen. They call it swollen baby fever or virus infection. It can also, of course, produce your, pain in the chest, pain in the abdomen, pain in the back. All of those are present. And there's always some conjunctivitis that is associated with your Lassa fever. And of course, it's caused by that Lassa virus. And that's one of your arena viruses. LCM is another one that's listed in that chart that we gave you. So that would be another example of an arena virus. A third example is called Machupo virus. The Machupo virus is an RNA virus, or RNA containing virus. This is an arenavirus. And it produces hemorrhagic fever. And it is found mainly in Bolivia, at least that was the origin. And so the disease it causes is referred to as the Bolivia hemorrhagic fever. And that's an example of your arenavirus. Very deadly infection, about 25 to 30% lethal. So about 25 to 30% of the cases will result in death. So that's another example of your arena viruses. And then we can have orthomyxovirus. And your orthomyxovirus group, that's where your influenza type A, influenza type B, influenza type C, that's where they belong. So, A, B, and C are orthomyxoviruses. And then you can have the paramyxoviruses. Paramyxoviruses, those are the ones that can cause para-influenza. Give you para-flu, para-influenza. So you can have pneumonia from that. You can have some upper and lower respiratory tract infections. And under your paramyxoviruses, you have respiratory syncytial virus, RSV, respiratory syncytial virus, and of course you have measles. You will see listed in there as one of the outcomes of that infection, rubeola. You know, when you say MMR, measles, mumps, and rubella. Okay. The R there is actually supposed to be rubeola. Rubeola is different from rubella. Okay. If you look towards the bottom of that chart, where you have your toga viruses, you will see rubella. Rubella is the one that causes German measles. German measles is different from your regular measles that this rubeola causes. German measles. Okay. So German measles or rubella is a toga virus, not a paramyxovirus. So they are very different. And of course, respiratory syncytial virus that we used to take as a child infection is now known to infect even very old individuals. And you have some vaccines that have been developed against your RSV. So those paramyxovirus will be responsible for your mumps, measles, and rubella. when did we mention mumps? Where did we mention it before? Where did you come across it? Okay. If you go back to your notes last semester under thyroidism, hyper and hypothyroidism, we mentioned the Quervain's condition, and we said that, you know, a patient that has mumps would be more likely to develop that the Quervain's thyroiditis. But anyway, so we have that as an example. Then picornaviruses. Picornaviruses tend to produce, or in this group, you have your enteroviruses. Okay. So that we can see. And you would also see that under this big group is where you have your polio viruses. Okay. See, that's where you have your polio, and you also have a lot of GI infections being produced by your enteroviruses. And you would also see echoviruses being listed under there. So Coxsackie virus belongs also to your picornaviruses. When people go on those trips on the ship, the ones that go along Atlantic Ocean, and they come back very sick with a lot of GI conditions, you know, it is usually due to Coxsackie or to your rotavirus. So those ones cause a lot of GI related conditions. Let's see, rotavirus is not a picornavirus. It is a Rios virus.
So is rotavirus the one that people go on the ships and get sick, or the other?
Okay. The Rio is a group. The particular agent there is rotavirus. So that, along with your Coxsackie. Coxsackie belongs to a different group, the picorna group. So Coxsackie and rotavirus are the two specific viruses that usually cause GI-related conditions. You know, when people, you have a lot of people being in the same environment for a while, and one gets the infection and it is very easily transmitted. So a lot of them come down with those GI conditions. Okay. Now we also also have coronaviruses. And coronaviruses are the ones, that's the group, okay? Coronaviruses, among them you have your SARS, and you have your MARS. And then, of course, you have your COVID-19. Okay. And MARS is your Middle East. Middle East respiratory syndrome. You know, SARS is severe acute respiratory syndrome. Okay, and then COVID is actually SARS-2. SARS-CoV-2. Okay. So those are your coronaviruses, and we'll talk about COVID-19 down the road. And then you have some RNA containing viruses that are called alpha viruses. So alpha virus is a group of viruses, and it can produce that triple E, that's equine. Eastern equine encephalopathy or encephalitis. So triple E is a specific organism that is within the alpha virus group. And your triple E can also be very severe. It can suddenly have fever, and then the fever develops or progresses into muscle spasm, muscle ache, and then eventually muscle weakness, and then paralysis. All of those are manifestations of that triple E infection. And then seizures is also present, and photophobia is also present. It is more dramatic in children because, you know, the child is playing yesterday or today, and then later in the evening, all of a sudden they can't move their limbs. It's like paralysis. And that often gets the attention of the patients, of the parents. But the infection belongs to that alpha virus group of viruses. And then you have the retroviruses. And that's another group, big group, and that's the one that would contain your human T cell, HTLV, that is T lymphocyte virus, HTLV1, HTLV2, HTLV3, and of course your HTLVs usually produce leukemias. So they can cause cancer. HTLV3 that's the one that was initially suspected to be the cause of HIV. Because if you look at the manifestations of HTLV3 infections. You will have that adenopathy. You know, which is something that's very common or that's very prominent in your HIV infections. And the drugs you would use to treat HTLV3 infections actually worked in HIV patients also initially, and then it fell off. So that was why everybody thought that HTLV3 was the cause of HIV. But then, of course, we found out later that you do have your HIV virus, which causes AIDS. And HIV virus is of two types. You have HIV-1 and HIV-2. HIV-1 is the one that causes AIDS. HIV-2 does not cause AIDS. Okay? There are actually two divergent viruses. So HIV-2, even though it causes lymphadenopathy like your HIV-1, it does not cause AIDS. And some funny things happened like around 81, 82, 83, and so on. People who had HIV-2 were actually resistant to HIV-1 infection. So that was the reason why people thought that your HIV was man-made, because HIV, that was the first time that infection occurred in human beings. And if you look at the genome, it seems like it was a combination of that Yersinia virus that we looked at before and equine virus. If you join those two together, what you will see will be just exactly like HIV, like AIDS virus. So, but there were some questionable things about it. And up till today, nobody knows the origin of AIDS. We wrote something about it in the 90s. It's still a mystery. So those are retroviruses. Sometimes you can see the term lentivirus that refers to your HIV group. And then you have the rabies virus, which belongs to the rabidovirus. And of course, we know that can cause rabies, and it can also cause meningitis. Some situations. There's a virus that we all know, Ebola virus. Ebola virus used to be classified as a rabidovirus. It used to be classified as being in that group. But now that has changed. So Ebola virus is now classified as a filovirus. So it's no longer classified as a rabidovirus. And if you look at Ebola, the key letter there will be that B to refer to bleeding, because that's the essential characteristic of Ebola virus. The patient, blood will be coming from everywhere, from the eyes, from the skin. In fact, it's called bleeding out, and you're not supposed to touch anything, even the clothing of a sick person, because if you touch that clothing, especially without gloves, you can contact that Ebola virus. And then the face will become fixed. Like a mask. So they have one fixed face that does not express any emotion, or the muscles don't even move. It just gets fixed like that. And then the eyes will roll to the back because of the shock that is associated with Ebola virus. And then death would occur within 2 weeks, usually less than that. So it's a serious disease that has now been reclassified as a filovirus. Okay. And then you have your toga viruses. And the toga viruses would include that rubella virus, the one that we said will cause German measles. Okay, so that will be one of them. And you have some encephalitis viruses. This group of viruses that usually cause encephalitis, and they belong to that large group, toga virus. So you have the rubella, and then you have the arboviruses. The arboviruses belong to the big group, toga viruses. And within this large group of viruses that you call arboviruses, there are some that belong to so-called group B. Group B arboviruses. And the group B arboviruses, there are about 66 of them, but we'll just mention maybe 2 or 3 that are common. Yellow fever. Your yellow fever virus is a group B arbovirus. Okay. And of course, it causes hemorrhagic fever. So that's one example. Your dengue fever. That is another example of your group B arbovirus. Okay. And let me put chikungunya. That's another member of that group B arboviruses. Zika, know, we had an outbreak not too long ago of the Zika virus infection. So that is also a group B arbovirus. Okay. All of these are actually transmitted by mosquitoes. And here you are talking about the Aedes aegypti. Aedes aegypti. Two of them, you know, this dengue fever and chikungunya fever can also be transmitted by Aedes aegyptus. Okay.
Doctor, no, the Aedes aegypti is the mosquito that causes all of
No, that transmits. That transmits the virus, just like Anopheles mosquito will transmit, you know, the cause of malaria. Okay. So sometimes you can see that dengue being referred to as a breakbone fever because it is always associated with excessive seizures, you know, and of course then they will have fever, they will have headaches, you know, all of those are present. But that jerking, that, you know, seizure is why they call it the breakbone fever or breakbone disease. Chikungunya and Zika are similar in a way. They are only caused by the female, only by the female Aedes mosquito. And the Zika virus is transmitted by that Aedes mosquito that would only bite during the day, not in the evening time. And it's only the female mosquito that will carry your Zika or your chikungunya. Okay. And this whole group B arboviruses, you can also see them referred to as your filiviruses. Okay. And for the last part of viruses, you have a West Nile, encephalitis, and you have the St. Louis encephalitis. And those two are also carried or transmitted by mosquitoes. By the Culex mosquito. Culex univitatus. universalis. So Culex universalis is the one that carries your West Nile, and Culex dorsalis is the one that carries your St. Louis encephalitis. Okay. Um, so we have an idea of some of the viruses, and now we can look at how the virus then gets into us to cause an infection. That lifeless particle will be attracted to a human cell. It's usually an electrostatic type of attraction. So the virus is attracted to the human cell or the human body. And after that attraction, the virus moves towards the host, and it will try to attach itself to the host. And that's usually because there is some kind of receptor for it. And so then it would bind to that receptor. This is all happening on the outside. And when the virus binds, it would gain entrance into the host cell either by fusion, that is, it just fuses with the cell membrane for the host, or by pinocytosis. In other words, the cell would invaginate until that whole virus gets into the internal cell. That is, if you have the receptor like that and you have the virus over here, the membrane will keep invaginating on down like that, and the virus will be moving with it until the virus now gets over here, and the membrane can then reform. So the virus is on the inside of the cell. That's essentially pinocytosis. So it's either that the virus binds, fuses with the membrane, and gets inside, or it goes through that pinocytosis and then gets into the cell. And then the virus would uncoat. It will remove its protein coat, thereby exposing its genome. If it's an RNA virus, you see the RNA. If it's DNA, it's DNA that you will see. Sometimes some viruses have double-stranded genome, like double-stranded RNA. And the uncoating of the virus actually needs the help of the host cell also. So the host cell enzymes also help to uncoat that virus, so that the genome of the virus is now released into the cell medium. And then, depending on the virus will use the host cell genome to replicate itself. And then, through replication, it would eventually undergo, translation. Okay. So you get transcription, it will transcribe the host genome, and then it will be translated into a virus protein. So a new protein is formed, or a new virus is formed. And then the proteins of the virus will now be assembled. So you can form envelope protein, you can form proteins that will be needed for the capsid. All those will be assembled and they will be packaged. And then that variant, in this situation, you now have what is called a virion. So that virion can then bud out of the cell, and that budding out can lead to the death of the cell that was infected. So that's generally the pattern of viral infections. Some few changes here and there when we get to HIV and your COVID-19, we'll cite some changes or differences. Okay. So based on that general pattern of infectivity, we can now divide our drugs into those that would affect different stages. So everything from initial attraction all the way to that uncoding is referred to as early events. Okay. And the replication process, that is referred to as the middle event. Okay. And then everything from packaging all the way to budding out is called the late event. That middle part, that is the replication and all that, that is where your nucleosides are involved or play a role, and your nucleotides, they play a role in all that replication stuff. So, and sometimes we refer to that replication process as the synthetic stage. And that's where all your nucleosides and nucleotides will play a role. And so we can now start off with agents that affect the early events. The binding, the attachment, the entry, uncoding, all of those. So that's where we will start off. And we'll begin with the agents that inhibit neuraminidase. I will take oseltamivir as the example here, as the primary example. So oseltamivir is called Tamiflu, and if you're looking at your influenza, you always talk about A, B, C. Okay, with the A being the one that mostly infects humans. And that influenza A has some antigenic subtypes. Okay. And you always hear of H and N. You talk about H1N1, you know, H1N5, and so on. H1N1, that's your swine influenza. That was one, that was avian, that's H1N5. Okay. That H refers to hemagglutinin. And the N is actually neuraminidase. So when you say H1N1, the H is hemagglutinin, the N1 is neuraminidase. So it represents an antigenic subtype. Okay. And that enzyme, because it's an enzyme, neuraminidase, that enzyme does some things for the virus. You know, it's absolutely needed by the virus because it is involved in the transcription process. It is involved in the packaging, that is the assembly that we mentioned, and it is involved in the process of budding out. Because when the virus buds out, that's when it goes to infect another cell. And all of those will then be inhibited by a neuraminidase inhibitor. So taking Tamiflu as the representative, so we know the mechanism of action. We will simply inhibit neuraminidase and thereby inhibit all those processes in the virus that we talked about. In terms of its ADME, Tamiflu is administered orally. You give it pure, and it's given on a BID basis. The amount that you give would depend on the age of the patient. And we usually say, okay, if you look at your Tamiflu, you have 75 milligrams and you have 60. It's in order of 15 milligrams difference, so your 45 milligrams and then 30 milligrams. So the weight, rather, not the age. If you look at the weight of the patient, if the patient is less than 15 kilograms, in weight, you will use the 30 milligram strength. Okay. If they are between 16 and 23 kilograms, you will use the 45 milligram strength. And if they are 24 to 40 kilograms, use the 60. And then, of course, greater than 40 kilograms in weight, you use the 75 milligrams. And you will use all of those on a BID basis for treatment. If it's for prophylaxis, you will use it on a QD basis. So that's how it is dosed. And also Tamiflu itself is actually a pro-drug. It's a pro-drug. It is converted to the active oseltamivir by some esterases. So it does not use cytochrome P450 system for its biotransformation. Okay. It's just from hepatic esterases that it uses. And the amount that is administered must be given within 48 hours of the onset of that flu. Beyond 48 hours, the effectiveness is doubtful. So you want to give it within 48 hours of the onset of the flu. And if we look at the half-life, for the parent compound, it is about 1 to 3 hours. But for the active metabolite, it is about 6 to 10 hours in terms of its half-life. And if you look at the plasma protein binding, the plasma protein binding for the active compound, which is really carboxylate, it is about 42% plasma protein binding. But if it's for the parent compound, the one that is inactive, if you will, it's only about 30% plasma protein bound. Okay. And the excretion, of course, is mostly renal for your Tamiflu. And the indication, basically flu, and it works in both A and B. It works in both of them. That is influenza type A and type B. And if we look at the adverse effects, it affects the pulmonary system. So you can see things like cough, for instance. Cough, you can see bronchospasm, bronchospasm, and bronchitis. So bronchitis, bronchospasm, cough, all of those are pulmonary adverse effects of your oseltamivir. And then you have some GI related adverse effects, nausea, vomiting, diarrhea, those can be present. ENT, ear, nose, and throat infections are also observed during therapy with oseltamivir. And then you can get some sinusitis that present, and some dizziness that may also be present. So that's what you have for the oseltamivir or Tamiflu. Zanamivir is Relenza, and that is inhaled. It's not oral. It's inhaled through the mouth, so it's an oral inhalation. So you have the packets that you put in a device and inhale, and it's the same thing for Tamiflu. You have to give it within 48 hours of the onset of the flu. And people who are using, people who are, say, asthmatic, who are using some B2 agents, they have to use their anti-asthmatic drug before they use this Relenza. Rapivab is another neuraminidase inhibitor, but that one is administered by injection. You give Rapivab IV, and you give 600 milligrams, and it's only once. It's helpful for that flu A and flu B. Okay. That's one class. And then Xofluza. Xofluza is also a prodrug. It is also a prodrug, and it has a different mechanism of action, though. Xofluza tends to inhibit the endonuclease activity. It inhibits the endonuclease activity of a polymerase acid protein. And that's what we say PAP. So it inhibits the endonuclease activity of that protein, that polymerase acidic protein. And by so doing, it inhibits the transcription of the viral genome. If we look at its ADME, it is administered on a PO basis. And the dose that you give depends on the weight of the individual. If you are less than 40 kilograms, you get 40 milligrams. And anything above 40 kilograms, you get 80 milligrams. And that's the thing. It's only a one-time dose and it's administered orally, and it's very effective in that sense. About 92 to 93% is its plasma protein binding. The half-life is about 79 hours. About 79 hours. It is biotransformed by your 3A4, so it's metabolized by 3A4, and it is also biotransformed by your UGT, that is uridine diphosphate glucuronil glucuronil transferase. This is transferase. So uridine diphosphate glucuronil transferase. And it's usually the specific one, 1A1. That is UGT 1A1. Okay. So that's how it is biotransformed. And in terms of the excretion, it would also go out through the renal system, after that biotransformation. Indication will be the flu, and the adverse effects would be mainly GI related, okay. And then it can affect the pharynx. It can give you pharyngitis. What? What's the question?
When you say if pharyngitis, like, because pharyngitis is caused by bacteria, right? Like, giving them medicine makes bacteria?
No, it's just inflammation. Yeah.
Why?
Okay. And so that's how that one is used. enfluvertide. Enfluvertide is really a combination, a synthetic drug that contains about 36 amino acids. And it inhibits, in terms of its mechanism of action, it tends to inhibit the first heptad repeat. Just say HR, but that means heptad repeat. What that means is, if you, okay, let's take HIV for instance. If you look at the envelope protein for HIV, you have GP160. The GP160, that is glycoprotein 160, is then divided into your GP41 and GP120. Those are the glycoproteins that make the envelope of your HIV. Okay. This GP41, when you look at it, it has a structure, I would say a structural motif. That consists of 7 amino acids that are repeating, every time down the chain. So that repeating structure of 7 amino acids is what you call a heptad. Hep, 7. Okay. Heptad repeat. Okay. So the very first 7, that is the first heptad, is what that enfluvertide would inhibit. Okay, so that's by inhibiting that, then it would basically inhibit that action of your GP41, which of course is part of the envelope, and that's why we say it's an early event action. Okay, so that's the mechanism. And the drug is actually administered subcutaneously, and it is 90 milligrams. That's how it's from 90 milligrams per mil, and you give 2 doses. That is on a BID basis. That's how it is given. It is not a substrate for your cytochrome P450. Okay. It just undergoes hydrolysis. So it is just broken down, proteolytically to its component amino acids. Okay, that's how the drug's action is ended. It undergoes that proteolytic hydrolysis to its component amino acids, and then that gets excreted. The half-life for the drug is about 3.8 hours, and the plasma protein binding is about 92%. terms of its adverse effects, the number one adverse effect is injection site reaction. Injection site reaction. That's its number one adverse effect. The second is, of course, pneumonia. You know, and it can cause some headaches also. So headaches, injection site reaction, and pneumonia are the adverse effects for your Fluvautide. And this one is mainly used for AIDS, HIV/AIDS. We're not talking about an anti-flu drug here. So that's for HIV infections.